That's very kind of you, but a lot of hospitals don't like me at all because I challenge them. So I'm a bit of a pain in the backside to most consultants in other hospitals. But that's been me since I started nursing. So, well, you're the last lot. Usually when I'm doing conferences and I'm the last talker, most the students or the guests have gone by then or they've fallen asleep. So really this is to talk about tracheostomies. I put NIV in there as well, non-invasive ventilation, purely because I just wanted to go over some masks and what have you. I've got some tracheostomies with me, so if you want to know what they look like, then I can send them round. There's a box here. You can pop those around. For those people who don't really know what a tracheostomy is, I'm very lucky with my job because I have the best of both worlds. I go into acute hospitals, but the biggest thing that I love is seeing patients out in the community, in their own homes, and enabling them, to be themselves again. They may not have been what they used to be, but they can be something else, and that's really exciting. So my job is not to tell you what to do. My job is to work with you and enable you to move forward on your journey through your life. So one of the questions was, what is the right mask? Now that is a good question because there's masses and masses and masses out there. And I think the first thing you need to ask yourself for non-invasive ventilation: do you want a nasal mask? Do you want nasal pillows? Do you want a full face mask? Is it comfortable? Is it going to allow you to talk? Is it going to allow you to eat? Is it going to cause pressures? Is it going to cause a leak? So there's lots of questions you need to ask before we start thinking about what the masks you have. Now, we're very lucky at the Brompton because we have a myriad of masks we can tap into and try out. In other hospitals, they may only have one or two. And sometimes they'll say, no, we can't give that mask, it's far too expensive. Which is not very cost effective because if the mask doesn't fit properly and you have lots of problems, then you end up having to take your child or yourself back into hospital again because you end up with a chest infection or because you've got sores or the ventilation's not working appropriately. So really, having the right mask is exceedingly important. And what we try to do is that if somebody has to have non-invasive ventilation during the day, we try to give them a nasal mask or nasal pillow so they actually can then communicate during the day, eat and drink if they still can. So here are some of the masks. There's full face, nasal pillows, lots of yummy things. I really can't work these things because I can do ventilators, but I can't do computers. Somebody talked to me about Twitter today and I just looked at them in horror and don't know what that is. So lots and lots of masks. She looks far too well to have a mask. And as I say, we're very lucky at the Brompton because we can get hold of any masks that you need. And as Anita Simon said earlier, we hopefully are going to go to a better technology of mask fitting. And also remember there's the 3D printing coming out now, and that 3D printing will be very individualised to the patient's mask, to the patient's face. So again, things will evolve, which is very exciting. So is there an alternative to interfaces for daytime ventilation? Well, I'm sure you've seen Josh at the back who's got his mouthpiece ventilation. And there's mouthpiece ventilation. Who uses mouthpiece ventilation? Who's not used mouthpiece ventilation? But it's something you can start with if you're having to use NIV during the day. And it allows you to be able to just suck some volume into your lungs, ready to move on, so you don't have to be attached to the ventilator all the time. And it can start if you've noticed that you're more breathless than ever, or that you're more breathless in the afternoons, or you've got a decreased audibility in your speech, because that's going to give you the volume in order to be able to speak. The settings were going to be set by your clinician or the physiotherapist. You need to start with a good volume, so greater than 1 litre. There should be no end expiratory pressure, so no PEEP. There should be no backup rate on it. It should have a long inspiratory time. And what's lovely about the Trilogy with Respironics is that it has a KISS trigger, which I love. So you can just go, and you get a breath. So that's what it's called, kiss trach, because you just put your mouth to the mouthpiece and you're just kissing it and it will deliver the breath. So you actually don't have to be very strong in order to get a breath. So it's a really, really nice way of giving ventilation throughout the day, but without having to be attached to it. But the trouble is, sometimes we have to give patients tracheostomies. And the current problem we have, and Michelle alluded to this, and this is something that I'm taking up as a nurse from the Brompton, is that the Royal College of Nursing this year sent out a paper about care in the community for children and young adults that stated that only registered nurses can carry out any deep suction. So not oral suction, but deep suction. So the suction from your ear to your nose and any tracheal suction. Now this is absolutely disgraceful because there was no stakeholder discussion prior to the publication, so nobody from the Brompton was contacted, nobody from Great Ormond Street was contacted, nobody from any experience in the community was contacted. So no carers, no patients, no nurses, no family members, no parents, and it was just sent out. So it is going to have a huge knock-on effect for some families and for some patients. But we are going to be challenging this from the Brompton and my colleagues from Great Ormond Street as well, because its impact is huge. I mean, this is ridiculous. I don't know, first of all, I don't know where they're going to get so many nurses from, because there aren't enough nurses anyway. So it's crazy. And nurses aren't the best people to always be suctioning anyway. We need expert carers and expert parents to do that. And what about the poor patient who actually suctions themselves out? They've got to get a registered nurse to bring into their homes to suction. So it's just crazy. Anyway, I won't go on about that, but that's just, if you do hear about that, that's the problem. So tracheostomy tails. So tracheostomies can be put in anybody or anything. So here we have a couple of animals, a cow, which has a speaking valve on, so it can moo. And a wee doggy, and he does bark. But these are from America, and they're not the UK. But it doesn't mean that they can't have tracheostomies in England for animals. I just wanted to go and take you back in time for why tracheostomies are around. And tracheostomy itself, the word tracheostomy, is derived from two Greek words, meaning I cut the trachea. And actually, it's been around for millenniums, basically. It was referred to in the big Rig Veda, which is a sacred Hindu book of medicine, in the 2nd millennium BC, and it was referred to in that. The first successful tracheostomy was recorded in 1546 by an Italian physician, and in 1800s it was performed in children with diphtheria. And basically, they just cut a hole in the trachea and let them breathe that way to reduce from all the swelling and the obstruction. And then in 1909, Chevalier Jackson refined the technique in France, and that's where you get the Jackson tubes from, which they use in America, not so much in the UK. So this is one of the wards that they used to have, the diphtheria ward, and all those children have got tracheostomies and all look very happy, and they're all alive. If they hadn't had those tracheostomies, all those children would be dead. So we used to have lots of wards like that. So what has been a big change over the last 60 years with tracheostomies out into the community, tracheostomies in hospital? And certainly when I started in intensive care in the early sort of mid-80s, early to mid-80s, we didn't have intensive care units then, and we certainly didn't see many tracheostomies. Those tracheostomies we did see were very long-term, or they were patients who had laryngectomies and they had the silver negus. So certainly we didn't see that many children. But in the last 60 years, there have been three major developments. We've had intermittent positive pressure ventilation and intensive care unit development due to the polio epidemic in the 50s. We then had an introduction of the low pressure tracheostomy cuffs that you see now. So there used to always be high pressure cuffs that cause an awful lot of damage within the trachea itself and cause tracheomalacia, stenosis, lots of issues where you had to take the cuff down every hour on the hour to stop that pressure. Then we saw the percutaneous dilational techniques in 1969, which allowed ICUs to do tracheostomies in the unit rather than having to go to theatre, so they didn't have to have surgical trachees. And also we've had a development of very creative and imaginative people like yourself to say, actually, we can look after these people out in the community. We can manage tracheostomy tubes out into the community, and we can make it a normal living and a normal life with a tracheostomy tube. Lots of reasons why people will have tracheostomy tubes, but patients with myotubular will have them because they will require long-term invasive ventilation because they can't manage the NIV anymore, or they were that sick that they needed tracheal intubation. They may have some tracheal obstruction, so upper airway, stenosis, abnormal vocal cords. They may have tracheomalacia. Tracheomalacia is where the trachea itself collapses. So without the tube in, the trachea will collapse. Or the patient his secretions become so unmanageable and they're not unable to clear their secretions effectively despite all the adjuncts that you can do, despite all what Michelle had suggested. It may be that you have to go down the line of a tracheostomy because it is better for that person to go. And it doesn't mean that they can't have a normal life. So lots and lots of tracheostomy, different types of tubes. There's cuffed tracheostomy tubes, there's uncuffed tracheostomy tubes. There's single lumen, double lumen, fenestrated, unfenestrated, PVC, PU, which is a polyurethane, silicone, silver, subglottic ports, and differing lengths and curvature. And they should be all individually made for your patient. So if you've got a patient who's got a tracheostomy that's not working, there should be another one you should be able to go to. So not one trachea will fit all. So not one make will fit all. And there's lots of different makes: Capitex, Portex, Shiley, Jackson, Negus. But whatever is put in may not, at the very beginning, be the right one for your child. And you may have to question that. So be armed with information. That's my motto in life. The problems with putting a tracheostomy is that we then bypass our normal first line of defense. So we all breathe through our nose, and we breathe through our nose and through our mouths to warm, humidify, and filter the air going through, okay? We also speak. So we speak through our mouth because we speak on expiration, so our vocal cords close together and we can then phonate. It's very difficult to speak when you're breathing in. When you breathe in, it's very difficult. So you can't do that. So very difficult, okay? It also helps us swallow, it helps us cough, and it gives us a subglottic pressure back. So that's our normal upper airway, and we just take it for granted. And if we don't have that normal upper airway flow, then all of those normal physiological things and anatomical things do not happen. Okay, so you get physiological changes when you put a tracheostomy tube in. So in this diagram, you can see the tracheostomy tube is here, your vocal cords are up here. If that tracheostomy had a cuff, there would be no flow up to the vocal cords, so the patient wouldn't be able to have any noise or phonation at all. But you have bypassed all of this humidification and first line defense. So the air will go in there and will come out of there, and some of it will go up there. Depending if you've got a cuff, it won't. It'll come straight out there. Okay. When you touch a ventilator, the ventilator will push the air down here and then come back out again. Okay. So you'll have lots of physiological changes. So that means you may not get speech, taste and smell will change, swallow will change, cough will change. You also will get some altered body images. I mean, how many times if you've got a little one with a trachea and trachea ventilated, you go down the street and they'll go, bloody hell. You know, people don't know what it is. They don't know, and they will stare. So as the child grows up, they're going to be much more aware of themselves, and they will get an altered body image. So it's really important that we start normalising it. The trouble is with our society, it doesn't like disability. It doesn't understand disability, and disability is not sexy. Cancer's sexy, disability isn't. And we need to change that. And I'm going to fight to change it, because we've got to change it. And there's this lack of communication. They feel really vulnerable. And when you've got somebody, a child or a baby who's got a trachea, if they cannot phonate and if they can't taste and smell, because as you know, kids put everything in their mouth to taste it, to feel it, to smell it, they have that lack of sensory development, and cognitive development will be impaired. So it's really important that those do not have a cuff tube, that they have ability to take that taste in and get that taste stimulated, because what you're trying to do is keep that upper airway flow going, so you get a better, I'm going to start dancing in a minute, you're going to get a better taste and smell. You get reduced lifestyle because you're limited, because when you go out, and I've seen all of you who have trachea ventilated patients here, you have got to go out with 2 ventilators, suction catheters, suction thing, feed, this, that, emergency box, everything. So it's a big thing to go out with a trachea ventilated patients. But it can be done. And also when they come out of hospital, they try to medicalise you. And we're trying to demedicalise these people. You know, this is them, you know, you're not going to, they don't sit at home with a saturation monitor all the time, so why should your little boy or little girl sit there with a saturation monitor all the time? It's not normal. Try to normalise things and demedicalise them. So, what are the myths then of having a tracheostomy? Well, the tracheostomy cuff does not stop aspiration, okay? So that is a myth. That some of the anaesthetists, some doctors will say, if you have a cuff, we're going to stop aspiration. That is an absolute myth. It can reduce aspiration, but it will not stop it. They'll often say, you won't be able to eat and drink with a trachea. Of course you can. If you've got a normal swallow, or a swallow that is a bit impaired, but you can swallow, then you should be able to take some drink and some food. Often they'll say, you'll never be able to talk again. Well, if you've got normal glottic physiology and you can phonate, then you should be able to phonate. And if you can't, then there must be ways of trying to get you. It could be that, you know, you just have an anatomical reason why you can't talk, but that comment, you should never talk again, is rubbish. You won't be able to have a bath or a shower, rubbish. You won't be able to go home, rubbish. The tube will never come out, rubbish. Sometimes it does, sometimes it doesn't. It may not with yours, but saying these things that are black and white does help. It helps nobody. It helps nobody when you're so black and white, and we cannot be black and white. But that's because of our Western Eurocentric healthcare system. It wants to have evidence all the time about these things. Well, sometimes you can't give evidence because it's an innate feeling of knowing your little boy, your little girl. You know when they're not well, but nobody wants to listen to you. So when you decide that this person needs to have a trachea, we need to reduce the risks. And one of the ones is that you need to get the right trachea to do the job. So you need to get the right model, the right material, the right size, the right length, and the right curvature. Because if a silicone tube is causing lots of problems, then try to go to a PVC tube. So look at the material. If you're having lots and lots of secretions, is it because of the material of the tracheostomy tube? There's others on the market that you can try. If you're having lots of secretion, is it because the tracheostomy is too long and keeps abutting the posterior wall of the trachea? Is it too... so some of the curvatures of them can be like that, or they can be like that. So is the curvature wrong? So again, have a look, see whether the trachea is the right thing. The only way they can do that is actually having a look down. But you need to have a think about what is it. And I have a lot of ENT surgeons say, well, it doesn't really matter what you put in, but it does. It really makes a big difference. And something like a curvature that goes from there to there will make a big difference to secretions as well. Once you've made that decision that you're going to have a tracheostomy, you then need to plan for discharge, and you need to have all those people educated that is going to be part and parcel of that care package. And remember, it is not critical care that they're going back to. They're going to go back to a home life, which is not critical care, which is going to be normal for them. So we've got to get the right training. Have we weaned them optimally in hospital? And is there going to carry on being some weaning at home? So if the cuff can't come down in hospital, can we try getting it down at home? Because things change. When you get home, it's so much better because people thrive when they're home. They don't want to be stuck in a horrible ward in hospital with people telling you what to do and what not to do, and you can't touch your child because you aren't the expert. Drives me bananas. And you need the right equipment. So part of that equipment then is your emergency bit, and this is the essential equipment. I'm not going to go into all the big spots and do's, but so you of course you've all got mansions to have all this equipment for all your patients. So you need an emergency box, so you need your 2 spare trachea tubes, one the same size, one size smaller. You need a trachea tube license to say what tube's in, what secretion management's on, what ventilator they're on, what cough augmentation routine they're in. You need your consumables, you need your suction machines too, with batteries, so that if there's a power cut, you've got a battery backup. If your patient is ventilated, if your loved one's ventilated, you need to have 2 ventilators, and they need to have carry bags, spare batteries, and you need some humidification, and you also need your resuscitation bag. So that's your essential equipment, and of course you need your wheelchair if you've got somebody who can't walk. And if you become an adult, getting a wheelchair in adult services is a nightmare, just to pre-warn you. So order it now, and it might be ready. And part of having a tracheostomy is about holistic, collaborative and integrated management. It's not about one person, it's about a team. And that team begins with the person who is not well or has got the trachea or needs trachea ventilation. The team around them means that it's going to be a big team of parents, brothers, sisters, aunts, uncles, carers, specialists, consultants, physios, OTs, psychologists, speech and language therapists. And nobody should be saying, you're going to do it this way because I've always done it. That should be, if somebody says that to you, you challenge them straight away. Oh, I've just done that one. So having a trachea, you also need to have effective humidification, and there's lots of different ways you can humidify, because you've bypassed this bit, so you've got to humidify here and filter. So there's Buchanan bibs. These ones are little bibs that help filter if you're not got a trachea that's you're not ventilating through. You've got an HME, which is a heat moisture exchange, and basically what a Buchanan bib and a heat moisture exchange do is that when you breathe out, and you can all huff on your hand, you'll feel that you've got a warmed, moist exhalation. That moisture then goes into the HME, into the filters, and then when the person breathes in again, they bring that moisture back into their lungs. If you've got a trachea ventilated person, then you're going to either use an HME in the circuit for the dry circuit, or you're going to use Fisher and Paykel wet humidification circuit for nighttime. Okay. Then you're also going to use adjuncts like nebulizers for added humidification. So if it's been dry, like it's been recently, you might need to use more nebulization because they're a bit dry. But the most important thing is that if your baby, child, or person is not eating and drinking, then you need to increase their PEG fluids. And we forget to do that. And even in hospital, I had a patient with myotonic dystrophy. She's PEG fed. In that really sort of hot weekend, they found out, oh, well, she's a bit dehydrated. I said, well, did you end up giving her any more fluid? Oh, no. So we will automatically drink water, but that person may not. So you may need to think about, have I hydrated my child properly? Speaking valves, Speaking valves there's two different types. You can have an upper airway restoration valve, which is your Passé-Muir valve, and they're the coloured ones, the green ones or the purple ones, or a clear one, or you can have a rush valve, which is an open valve. The upper airway restoration valves are the best one because they're a one-way valve and they allow air to go right up into the upper airway, so it restores your upper airway function. So you get your taste and smell back, you get your cough back, you get your swallow back, and that's much more effective. And you need to have effective chest clearance, like suctioning and other adjuncts, which Michelle talked about. I had a question is, why can't I speak with my speaking valve? And possible causes, it could be that the trachea tube is too big in the trachea. So when you've got a tracheostomy in a trachea, there should be enough flow between the tracheostomy and the trachea, so the windpipe. And if there's not enough flow between the windpipe and the tracheostomy, then you haven't got enough flow that's going up to the upper airway, and that will stop speech. You won't be able to speak and they'll get distressed with it. So if the trachea tube is too big, that one-way speaking valve won't work. So you may need to use an open speaking valve like a rush valve. If you've got a cuff tube, it could be that the cuff's not deflated and you haven't got any airflow up. If you've got an anatomical obstruction or dysfunction like your vocal cords, you've got granulation on your vocal cords, or your muscles are really weak and you haven't got enough flow, then it may be that they can't speak either. Or with the speaking valve as well, with the one-way speaking valve, they've got to be able to open that diaphragm. So you've got to be able to open that diaphragm by using about 2 centimetres of water. And some people might be too weak to do that. So change the valve to a different open system valve. We talked about what is deep suction, when should it be taught. So I'm going to talk about deep suction with tracheostomies. And deep suction with tracheostomies is a little bit different, and deep suction should be done to clear the chest secretions effectively. And it means a suction catheter goes down to the carina. There's the carina, okay? And your suction catheter goes down to the carina, and basically you'll know when you got to the carina because you can't go any further. You pull it back, then you do your suction. That is deep suction, okay? That is deep suction through a trachea, through the tracheostomy tube. And it's really important they do deep suction, otherwise you're not going to clear the secretions effectively. It's no good just putting it in, then taking it out again. It needs to go right down. The difficulty is that if it's done too forcefully, you can cause bleeding at the carina and damage to the carina. So it needs to be done correctly. And that's why with so for those who know these lovely suction catheters, they should be graded, so you've got them on 10 centimetres, 7 centimetres. This is an adult one, so yours probably aren't as long as that, but then you can find out exactly how far you go down. When your child's growing, it's going to get longer, okay? So as they grow, it will get longer because they're going to grow and your trachea is going to grow, so it's going to get a bit longer. So you might find you've been suctioning down to 10 centimetres, a year later you're suctioning down to 20. Okay, so just make sure that when you go out and they say the consumables, you get these type of catheters, suction catheters, with the gradings of the numbers. Okay, otherwise you won't know how far to go down. And that's easier for training as well. So who should do deep suction? Well, not just registered nurses. Everybody should be taught, to all those caring for a person with a trachea, or who want to be, because some family members don't want to be, but anybody who's going to be part and parcel of that care of that child, that person, they need to know how to suction. The training should start at the hospital prior to discharge. It's a clean technique, it's not sterile, and it should be adapted to each individual person and use number graded suction catheters, as I said. And with trachea tube changes, Again, who should be doing trachea tube changes? Well, ideally, all those who are caring for the person with a tracheostomy should be able to do a trachea change. And ideally, that change should happen at home. If it's a normal trachea change and there's no red flag, so there's no risk of tracheomalacia, there's no risk of granulation, and the trachea tube change has been deemed to be easy and that there's no risks. Well, there's always a risk, but the risks are very minimal. The tube should be able to change at home. That would have to stop you going into hospital every 4 weeks for a change, which is very stressful. It means that the patient is exposed to infection, and it's costly. And really, what would happen then if the tube came out when they're playing in the garden? Who's going to put it back then? And what are you going to do? So really, it should be done by the people around them. They should know how to do it, and it should be done at home. If it's going to be a difficult change, then of course go into hospital. But it's part of their being. It's part and parcel of their daily routine, monthly routine, weekly routine, whatever. And it should be part and parcel of how they are. That's it. Oh, it's time for a trachea change. Okay. That's how it should happen. And also, when you can do it at home, you're going to be much more careful than sometimes the clinicians in hospital. And I've seen where clinicians have really ripped tubes out and just shoved it back in again. And it's just ridiculous, absolutely disgraceful. Or we had a mum recently who changed the trachea tube for years and years. Now they've transitioned to adult services. The ENT surgeon won't let her change. Well, he has now, but he wasn't going to let her change the trachea tube. She's changed that trachea tube since the child was 2. He's now 19. So what we need to do with patients with tracheostomy tubes, we need to enable. With anybody with any disability, whether you've got myotubular or whatever, enabling people, that means you've got to risk take, but you've got to have a backup plan if you're going to risk take. You've got to get that person home as soon as possible. You've got to listen to the patient and the carer's narratives. Listen to their stories. Tell them what makes their little one tick. What works for them. Actively listen. We're so bad in the acute sector. When you go into casualty, if you ever have to use casualty, nobody listens to you. No, we'll deal with that. No. Well, it's not what I do. No, well, he's in hospital now, so you just have to listen to us. Why? Where's the rule book? Who says that they have to? Who says that you know more than I know, or I know more than you know? Nobody. We share knowledge. Never say never. That's my motto in life. We should have patient and carer forums so we can influence local and national policy, not having things sent out by the RCN without any stakeholder involvement, and where it should be coming from patients, families, upwards. We need to demystify disability. We need to be imaginative. We need to be creative. And in that way, we can enable a life worth living and get patients home, get patients swimming, and get them home to their loved ones. Thank you very much.